The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Thank you. I never thought I'd find myself in an autism conference when I started writing about environmental exposures. Kind of happened through the back door, if you will. I was an industrial hygienist. We were looking at people who said they became ill after exposures to organophosphate pesticides. Actually, it's organophosphorus. I just learned from Dr. Line a little while ago that I need to say that properly. And so we're looking at pesticide exposures. People became sick after their home or their office building was remodeled, or Gulf War veterans who became ill after an episode in the Gulf War. So we looked at these groups, and my interest in autism grew when I was on a sabbatical at NIEHS, National Institute of Environmental Health Sciences, when Ken Olden was a director there. And many of you may know him. What a wonderful person he is. Well, he hosted the first group of parents who wanted to talk to him about how environmental exposures may have caused autism in their children, or at least were triggering symptoms. And so I happened to be there, and I'm listening to the parents and all the symptoms the children were reporting and what the parents had problems with, including food intolerances, problems with very common chemical exposures, not tolerating caffeine, not tolerating alcoholic beverages, these kinds of reports, and they were so parallel, exactly parallel to what we had seen with people who said they became ill after these exposure events that I mentioned, that they said they became chemically intolerant after these exposures. And for a long time, the adults, who were 80% women, simply were not believed that that could happen to them. And so we kept collecting information. We developed the questionnaire that you have in front of you, which I encourage you to fill out, so you'll see the kinds of questions we ask. And then when I was at this meeting at NIEHS, noticed the parallels between autism and this chemical intolerance phenomenon. And little by little have been discovering that exposures may at least certainly trigger symptoms in children with autism, but also may initiate the process too. So we look at this as a two-step mechanism, and that's what I want to go through. So the title of this is Your Child Tilted? Let me be more specific what we mean by that, if I can figure out how to advance this. There we go. This is actually a cartoon of a mechanism that we outlined long before we got involved with autism. This was based on people who said they became ill after a particular event. And I guess I should have the little pointer here. Is the pointer here? This is. Okay. And I can use it from here. I hope I've got the right button. That one. Perfect. Okay. So this cartoon, and they say if you have a concept to communicate, even in physics, the best way to communicate it is with a cartoon. So this is a cartoon, essentially, of what we see going on after certain exposures. And again, I'll highlight pesticides, remodeling of a building, veterans in the Gulf War who had myriad exposures. And this is the kind of process that seems to be occurring. So there's an initial exposure event, and that exposure event then leads in susceptible individuals. It's not everyone, it's a susceptible subset. Oh dear. No, doesn't like me. Okay, I can't manage this. Okay. In a susceptible individual can lead to this loss of tolerance. And this is not loss of tolerance to everything, it's specific tolerance. So maybe to particular foods, environmental exposures, different fragrances, cleaning agents. And afterwards, you've got a sensitive individual that when they're exposed to these very low-level exposures that most of us tolerate, and these individuals tolerated previously, then these exposures trigger symptoms in them. So this is two steps: loss of tolerance following a major exposure event that these individuals could remember, and subsequent triggering of exposures by triggering of symptoms by everyday exposures. And the symptoms are many different ones, and those are the ones that are summarized on that questionnaire that you have. Often at the top of the list are cognitive, mood, digestive, and other symptoms that you're familiar with autism. That's exactly what we were seeing in these adults who had some identifiable past exposure. So then a physician comes along here. This is the second time I know you've seen the iceberg today. It's a little different depiction. Physician comes along, sees the symptoms, and not aware of what might have happened previously, and diagnoses maybe chronic fatigue or migraine headaches or depression or some other named illness in these individuals. They don't have a name for this process, and they may not even be aware this happened, and the patient may not be aware. So what keeps people from being aware of this, what's underneath the water here, the triggering and the loss of tolerance, is a phenomenon we call masking. So that if an individual has an exposure and subsequently develops intolerances for all those different things you see on that questionnaire, or at least many of them, then their symptoms overlap in time or recur one upon the other so that they can't tell what's triggering which symptoms. And that's called masking. So you get up in the morning, maybe you're in your house that has gas heat, use your gas stove, you put fragrances on, you're around some cleaning agents, you drive through heavy traffic, get to an office where there may be smokers. It's one exposure after another. And in a sensitive individual, the symptoms that they experience will overlap in time, and they can't tell exactly why their symptoms, why their headaches, why their depression is occurring. It just seems to be continuing and waxing and waning unpredictably. But it is not unpredictable, not if you get them what we call unmasked, and not if you get them away from those background exposures that are causing symptoms. And that's going to be something I'll address a little further, the need for environmentally controlled hospital units where we can do research and diagnosis and treatment for complex cases. So this might be autism, it might be individuals who have an autoimmune disease, things that we cannot get people to a clean baseline away from exposures and foods for long enough to determine what is causing their symptoms. So this is a research approach that's not available to us in this country, but has been adopted in Japan and some other countries. So this basically is a process that we call toxicant-induced loss of tolerance, or what the patients say is tilt, or they've been tilted, and it describes this process. So if you go to a doctor and you say, you know, I'm allergic, or your child's allergic, they know what you're talking about. There's a well-defined mechanism. But that mechanism was not understood in the early part of this century, or I should say in the early 1900s. It was not understood. We didn't have any knowledge of that mechanism. And certainly with infections and the germ theory of disease, that only occurred after the Civil War. So people didn't know, doctors didn't know, people didn't know why they were having fevers. So these two major disease concepts that we all take for granted now, the immune theory and the germ theory of disease, were not known as just 150 years ago. So we're learning. Yes? I'm sorry. So anyone who would like copies of these slides, Jane said just drop her an email and request them. Okay, you'll be welcome to have them. And of course, they'll be on the video when that comes out for the conference too. So this model it's like the germ theory, that's a particular mechanism. The immune theory of disease is a particular mechanism. Here we're talking about TILT as a particular mechanism of disease. And if we don't conceptualize it as being a different mechanism from what we're used to, from what physicians and patients are used to, it's hard to kind of wrap your mind around it. And what does it embrace? It embraces a lot of the things that have been discussed at this conference. Just like there are many different germs, it can cause many different kinds of symptoms and different fevers. There are many different kinds of antigens. It can cause immune responses with different manifestations. We're talking about many different kinds of chemical exposures, xenobiotics, that can induce different conditions, but they all share in common this general mechanism. Now, why is this important to know? Because if you go see a doctor and the doctor doesn't realize that now you are sensitive to extraordinarily low levels of everyday exposures, then they're not going to understand why you're complaining about fragrances or complaining about, you know, why you're sick in your house with the exposures from pesticides or gas heat. And it's a subset of the population. It is not a small subset. Our most recent study showed that among chronically ill patients coming to a family medicine clinic, 400 patients, 20% of them met the highest criteria for chemical intolerance based upon that questionnaire that you have. And that was a surprise to everyone, that that is such a common phenomenon, and yet it wasn't identified in most people's cases. Nobody ever told them they had chemical intolerances. Doctors just don't know to ask these questions. And this questionnaire is now being used clinically to help doctors identify this problem in patients. So you've seen this slide before too. If you've seen one child with autism, you've seen one child with autism. And when we look at from an environmental perspective, it makes a lot of sense because there's so many different exposures and so many different genetic susceptibilities, and timing may be different for different people. So it's when you deal with environmental exposures, you expect to see these kinds of differences. It's not like one single bacteria or one single immunological reaction. There, of course, are no genetic epidemics. I have to point this out a lot to my colleagues at the medical school because they'll say, well, this can be explained, this increase can be explained. There's lots of these studies saying it's genetic, but there aren't genetic epidemics. It has to be something involving the environment as well. And some of you may have seen this. This is a slide I got from NIEHS, but so the environment is what pulls the trigger and leads to disease. Now, autism prevalence, as we know, has increased dramatically over the last few decades, and it's interestingly how it parallels production of chemicals in our country. So if you start back around World War II, this can go backwards, it does, yay. If you start around World War II, there was almost no synthetic organic chemical production. It was all very limited. And then it rose exponentially and has continued to rise. And the same is true for pesticide production. Again, going back to World War II here, an exponential increase in the use of pesticides and changes in the types of pesticides used. We just heard about organophosphates and their use, that's again since World War II, and the increased production of those in the United States and now worldwide. So when Rachel Carson was here, she got people to ban essentially chlorinated pesticides, but many of those were substituted for by organophosphates and carbamate pesticides. So we have not only had a change in production levels, but also in the types of chemicals used. And if there's one single substance that the chemically intolerant individuals I've worked with point to as initiating this process, that two-step process, what initiated it was an organophosphate pesticide. And we've been studying this since it's the 1980s, and still it goes on, and now it's being linked to autism as well. Now, indoor air is so much more important than people give it credit for. We take it for granted, in fact, since we're in it all day long, and we kind of, quote, adapt to the odors and whatever else is in our environment. But 90% of us spend 90% of our day indoors. And inside, increased indoor air pollution sources, including synthetic organic materials, carpeting, pesticides that have been used, fragrances. I just got off of a flight coming over here. It was brand new 737, and it had plastic interior that still reeked. And then inside the restrooms, they put these little, plug-in or various kinds of air fresheners in a space that's no bigger than a telephone booth. So the levels of the volatile organic chemicals inside those restrooms are horrendously high. And we've been in homes of kids with asthma in South Texas. Children with asthma, and they may have 10, 12 of these air freshener plug-ins in their home, and then they wonder why they have asthma. That's the first thing we do is get rid of that. But the indoor environment is something that has changed dramatically since our grandparents or great-grandparents, depending upon how old you are. And there's less fresh air coming in. I'll talk about that a little bit more. And we have evolutionarily novel substances now, things that we were not evolved to handle. There's also a long half-life for some of these substances. We've done studies, we call these foam biopsies. We take a chair, like the one you're sitting in, and we take a little bit of the foam inside of it, the urethane foam, which is a passive collector for pesticides. We actually use that in doing air sampling, and found that chlorpyrifos in particular, in a home where it had been applied, the half-life was 4.5 to 6 years in that foam, which means it's absorbed into the material, and then it's re-emitted into the house. And as you saw from the earlier presentation, the levels are extraordinarily low, but that's all it takes. And you compare it to certain levels of drugs that we are administered in the micromolar levels, these are still very significant and extremely toxic compounds. Now, if you took an air sample from a new building or a new home, you'll see a number of volatile organic chemicals, which you take that air sample and you inject it into a gas chromatograph. You see a variety of peaks. Here, each peak represents a single VOC, or volatile organic chemical, present in the air of that home or an office building. And outside the same building, many fewer VOCs and much lower levels. The height of the peaks are proportional to the levels. So this is the kind of environment that's typical if you go to a home show, or you have a new home or a mobile home or a new office. You see complex exposures with literally hundreds of different synthetic organic chemicals present. And some of those can include fragrances and pesticides and other things as well. Some are semi-volatiles. These are just the VOCs, volatiles. And to complicate things, we've had a decrease in the fresh air that comes into homes. I think, how many of you are aware of this, that there's less air required in a building like we're in now and in schools today? Okay. So if you go back to the turn of the century, right back here, there was a requirement that, this is now for office buildings, you have 30, here's the 30 cubic feet, so think of a cubic foot. You needed 30 of those per minute, per person, for that particular office space. That's a lot of fresh air. And there were various reasons for that, but the main reason was back then, people didn't take a lot of baths. And it was very unpleasant to be in the same room with them. So, and that was before we had ventilation that was forced air kind of ventilation. Well, things changed over the years. People started taking baths. And here you had a decrease in the requirement, down from 30 down to 10. So down to 10 cubic feet per minute per person, which became a US standard and was incorporated into the most states' codes, building codes. That was further decreased in the 1970s because of the oil embargo. Some of us are old enough to remember that, right? And when the oil embargo occurred, we wanted to decrease our dependence on foreign energy. And so one of the big ways to do that is to decrease how much fresh air is brought in from outside into a building. Instead, you can just recirculate it and continue to, if you recirculate it, then you don't have to heat it and cool it as much, right? You just keep recirculating the same air. That's fine for the building owner who can reduce their costs for operating the building. Not so good for the occupants. And this is, in fact, when we started seeing the first sick buildings, was right here in the 70s, when that standard was dropped to 5 cubic feet per minute per person. And I served as a consultant to actually the EPA on their own sick building. They had a sick building in Washington, D.C. back about this time. And they had dozens of people at the EPA, and these were exposure scientists, scientists who deal with environmental concerns. And they noticed that they had just refurbished the building, put in new carpet, put up walls in various places that hadn't been there before. And in doing so, they decreased how much fresh air was getting into the offices, and many, many people became ill. Now, some became sick with what we call sick building syndrome, which means they recovered when they went home at night or on the weekends. Some of them didn't recover so well, and they developed a problem that we now call toxicant-induced loss of tolerance. And this is decades ago. This is in the 70s and 80s. And I still know of some of these individuals who are unable to go and work in normal spaces. They get sick around new carpet, like the carpet that was installed there. They cannot function, around fragrances and other things. And they've been disabled for their occupation. Many of them work at home from computers. Fortunately, they can do that. But this has affected several dozen individuals. Out of the hundreds of people that had sick building syndrome, there's a subset that developed permanent changes, permanent problems. So, and it appears to be lifelong. I mean, we thought, well, maybe this will go away in 5 years or 10 years or 20 years. No, they're talking about 3 decades here. So what is chemical intolerance? About 5 to 15% of people report multiple intolerances, the things that you see on that questionnaire that we handed out. And as I said, among chronic illness patients who are seen in a family medicine practice, routine patients, it's more like 20% who report multiple intolerances and have a high score in that questionnaire. And one of the questions that's often used on surveys is, do you consider yourself sensitive or especially sensitive to everyday chemicals like those in household cleaning supplies, paints, fragrances, soaps, garden sprays, or things like that? Those national surveys come up to about 15% of the general population. And what's interesting is frequently the intolerances people report include, it's not just chemicals you inhale, but it's foods, medications, alcoholic beverages, and caffeine. That seems to run together. So whatever is going on metabolically, whatever these people have to do to detoxify substances, it's not just inhalants. It's also these other things in their diet. And it's very much parallel to what we're seeing in autism. This is work that was done in Canada looking at genetic polymorphisms in people who were chemically intolerant. And there were certain polymorphisms. These are just combinations of genes. PON1 you see there, which is involved with detoxifying organophosphates. But I think what is most important is if you look at that last bullet, if people had 2 of these polymorphisms together, so like CYP2D6 and NAT2, which are very important for metabolism of various drugs and so on, if they had 2 of those, that they had an 18-fold greater risk of being in the group that were chemically intolerant versus in the controls. So the more of these polymorphisms the people had, the more subject they were to different exposures. And it kind of makes sense when you think about it. This, because it's a small slide, I'm not going to go into the details of it, but it's kind of going into the things that we've discussed. I have to do something with this. Where exposures occur in a woman when she's pregnant. Of course, there's detoxification mechanisms that are at play. So the liver plays an important role. But then in the fetus, the liver and the brain both have effects of these exposures. And I'm not going to go through this because you've probably heard so much about this in this conference. But it's conceptually thinking about the child, and we're not just talking about the adult who's chemically intolerant, but now a child. The mother and the child both may have differences in their ability to detoxify particular chemicals. So you've got a complex system involving mother and child. Now, we've looked at people who reported having, this is actually in cases of autism and ADHD. So these are individuals here, mothers whose children had ADHD and mothers whose children had autism, very strict definition of autism. And compared to controls, these were all more likely, except for the case of ADHD and vaccinations. But ear infections requiring tubes, twice as likely. In the cases, the mothers who had children with ADHD or autism, multiple infections requiring prolonged use of antibiotics. And look at this, 3.5 times as likely compared to controls, 6.5 times as likely in the cases with autism. And then reactions to vaccinations that prompted a call to the doctor was not increased in the ADHD group of mothers, but in those who had children with autism, it was 3-fold higher. And I think this gets to the point that these are individuals who react adversely to many different substances. It's not just vaccinations, it's not just pesticides, it's not just antibiotics, it's a variety of different things that you're going to see enhanced responses. And this is very significant and makes it understandable to me that someone whose child had some sort of adverse reaction and they call the doctor, they might attribute that problem to the vaccine itself, but in fact there may be a host of other exposures that can cause problems in that child. Now, another set of observations, this is again in mothers who had children with ADHD or with autism, ADHD and autism. The sensitivity in the children to odors like smoke, nail polish remover, exhaust, gasoline, air fresheners, cleaning supplies, higher in ADHD than among controls, and in autism, 3.5 times more likely. Food allergies or intolerances, somewhat slightly increased, but not significantly so with ADHD, but with autism, threefold. And then strong food preferences or cravings, that having to, just have to have that particular food and actually not wanting to eat certain foods, definitely increase in the autism group. And then allergies, just a moderate increase in both cases. And what I find this interesting because it's not like every mother that was surveyed was saying, oh yes, my child has problems with vaccinations. It was more so in the autism group than the ADHD group. So it's pretty strong evidence that yes, this is what's going on with the autism-affected children. And then strong food preferences or cravings, extremely high. I mean, it kind of fits what parents tell us, but all of these findings were stronger with the autism group than with the ADHD group. So how are chemical intolerances, I think I can do this now. How are chemical intolerances and autism alike? And this is really what started our quest. We saw in adults with chemical intolerance, right here, multi-system symptoms, especially neurocognitive, mood, and GI symptoms. You can see that they reported that these problems were initiated by pesticides and other xenobiotics, foreign substances, true also in autism. Food intolerances in both groups, food cravings, very strong in both groups, chemical intolerances in both groups, and then the presence of drug allergies, adverse drug reactions in both groups. And that's what was striking, because we've spent decades studying adults with chemical intolerance, and to see the parallel in children is not only striking, but it's frightening. Like, what happened here? Why is this going on with children? How can we determine the role of these complex exposures in autism or ADHD or autoimmune diseases or any other condition? And this is why it's been proposed we need environmental medical units to eliminate background exposures. And by using an environmental medical unit, we can determine, does a person improve if they avoid everyday exposures? And are there symptoms triggered when common foods and everyday exposures are reintroduced one at a time? And this is really the scientific way of discerning this, and of course looking for biomarkers at the same time. Now we're able to do brain imaging at the same time that we would do this kind of exposure study. We could do look at gene expression. So we have tools now that would allow us to document people's response in such a controlled environment. But it's a research tool, although it's been proposed and done elsewhere. Our NIH and the government has not decided to do any of this yet, so unfortunately. What is an environmental medical unit? Basically eliminates background exposures, background noise, and exactly what I said there. And this was an early conceptual drawing. The Japanese actually have built a unit along these lines. It's been done in private hands as well, but no real good published studies using these units. And there's a lot of feeling that if we could do this in the case of autism, the payoff would be huge. That we could really decide, will a child improve if they can be taken away from these exposures, and then identify which ones are triggering symptoms. And it's a very arduous thing to try to do on your own if you're a parent. I mean, to sort out all the things and get the organic foods and make sure the air and water and everything are clean. Yes, it's a recommendation, but to actually accomplish that and do it in a very pure way, to just figure out once and for all, does my child improve with this kind of avoidance? You can tell this is a little older slide. We did this about 10 years ago. So you hit a television that doesn't look anything like today's TVs. But even that was ventilated because the tubes, the electronics would give off various VOCs, using a floor that had non-outgassing grouting, non-outgassing materials, cotton bedding, very simple furnishings. And people have done this now, created kind of an oasis in their own home, or at least in a bedroom in their own for their own child. And it's very doable. And they can discern whether this has a big help for their child. Now, I want to go back to a study that was done by a gentleman named Theron Randolph back, this is, I'd say in the 50s, I think he did most of this work. So somehow I'm leaning on something here that doesn't like me. So this is a 10-year-old child that he saw in, I believe this is in the 1950s. Extreme hyperactivity. He couldn't complete the interview that they had to admit him to the unit. He was kicking, shoving, pushing everyone around him, racing around the exam room, overturning furniture, and tearing papers. And the parents reported that his temper tantrums began about when he was 13 months old. Now, this was before anyone knew to call this autism. He was learning well until 17 months of age when he began to forget words he had learned. He became distant, unable to relate to those around him. He had to be transferred from one school to another, placed in a school for problem children, and tranquilized, and occasionally put in a straitjacket. The doctors had suggested that he might need certain drugs or vitamins, institutionalization. Feingold diet was used to remove most, but not all, of the synthetic additives in his diet. And he improved somewhat with the Feingold diet, so his mother sought a more personalized approach, which was this approach of putting a person in an environmentally controlled unit, and Randolph pioneered this in the 1950s. There was a history of sort of addiction to foods and caffeine and so on that led to a flare-up of his behavioral problems. And it was clear he was susceptible to everyday chemicals when they tested him in this unit. And they do that by removing the background exposures and then just having the child around like a normal cleaning agent or cigarette smoke if it's in the home or whatever was normally in that person's home. And then following those exposures, fragrance, nail polish, cosmetics, the child would revert to the same behaviors that he had before he came into the unit. After 5 days in the environmental unit, he had improved behavior. One of the interesting ones was reintroducing corn, led to a temper tantrum. Reactions also occurred to apricot, raisins, grape juice, yeast, beets, beet sugar, honey, lamb, hot dogs, corn, beef, etc. And you can see we're talking about chemical exposures and many foods in the diet. The complexity of trying to intervene and remove those things as a parent on your own is extraordinarily difficult. But what we need to do is understand this, that if indeed this is what's happening, and how is it that these intolerances are occurring? Is it due to this toxicant-induced loss of tolerance? We probably need to reduce exposures, like to pesticides, and remodeling in a home or a building when a person's pregnant, when a woman's pregnant, or when a child's small. Those are exposures that appear to induce this problem. Organic foods did not trigger symptoms in this child. It often does in other people. Honeydew, broccoli, peas, but when given as conventional foods, so that means they had pesticides or food coloring in them, it did result in the same symptoms, the hyperactivity, irritability, and the autistic-like behavior. So this child needed truly organic foods to stay well. Otherwise, it was impossible for his parents to cope with him. And Randolph commented in his manuscript, with appropriate diet, despite the supposedly, quote, incurable nature of his problems, specifically with autism, he's able to lead a normal life. And I think that's what we would all wish to know. Can we control exposures? Can we reduce exposures that might cause this loss of tolerance? So one of the sayings we learn in pediatrics when we train as medical students is children are not just little adults, and I think that's pretty obvious. But in certain ways, children are just like adults. We have detoxification pathways that determine our susceptibility. 90% of people, and children too, spend 90% of their day indoors. And we're all exposed to these evolutionarily novel substances by every route: inhalation, ingestion, skin contact. So even though we're not the same, we share so much of the same things in terms of environment. And then from the talk just prior to this, we see the susceptibility to organophosphates in mother and child. And I'm going to again ask for anyone who knows of a case where a mother was exposed and became chemically intolerant to whatever it was while pregnant. We have seen individuals in whom they've had children with autism subsequently, and of course they would share similar detoxification pathways. So it would not be surprising, but I think that needs to be in the literature so people understand. It's not just the mother at risk for developing these multi-system symptoms, but a woman who is pregnant also, can also affect her fetus. The questionnaire that you have there is something that we're encouraging doctors to use with their patients, not just with their adults, but with women who may wish to become pregnant, so they can decide Is this someone who's more susceptible? Should they be advising their patients to be more careful with the cleaning agents they use and not to use pesticides? It makes sense to us, right? You don't do that during pregnancy. But this questionnaire has been helpful in convincing doctors that they should identify the more susceptible individuals in their practice at a minimum and help them avoid exposures that may place their children at risk. And what we find when we do this is that nurses and the doctors themselves and others start seeing this, in other patients and in their families. And so it helps them sort of get their minds around the fact that, yeah, pesticides are not a safe thing to have in your home. We can't wait for all the studies to come out, every toxicity study, but if people can take this questionnaire and see in themselves that they're more susceptible individuals, it goes a long way toward convincing them to change their practices. So chemical intolerance occurs in adults who are more susceptible and can lead to this toxicant-induced loss of tolerance, TILT. In children, those exposures in utero or in the older child affects developing nervous system, immune system, endocrine systems, and leads to longer-term damage. And the earlier talks about organophosphates and how they may affect developing neurons. There are certain parts of the adult brain where you have a lot of turnover of the cells. The limbic system, particularly hippocampus, is one of those parts of the brain. In the adult brain, where you have a lot of turnover of cells, so if you insult that with organophosphate, then you'll have effects that are not unlike what we're seeing with autism. And so that's the connection between the adults with chemical intolerance and children who have some neurodevelopmental problem as a result of exposure. And of course, as we've said, the nature of the chemicals, what they are, the timing, dose, and the individual susceptibility will determine what the long-term outcome is. So the queasy that you have there is a validated published questionnaire. It's in the medical literature, screening tool for chemical intolerance. And it can be used for studies where if you want to do a treatment study or if you want to have people just try to avoid things and see if they get better over time, you can administer it before and after some intervention. 50 questions, self-administered, 12 or 15 minutes to administer. They can do it themselves. And what patients like is that doctors don't usually ask them these questions. And those who do have these concerns, this is very validating and helps them to understand they may be more susceptible. If they have a high score on this questionnaire, and you can see the scores on the scoring sheet, then they start to understand, well, that's maybe why I have these intolerances. My husband's not bothered by it, or my coworker's not bothered by it, but I am, because there's a significant portion of the population that is affected by these extremely low-level exposures. And this is, I worked for OSHA in the early days, training compliance office, I shouldn't admit that. But the levels of exposure there are so much higher than what we're talking about here. These are extremely low, part per million, part per billion, extraordinarily low exposures. And so for people to understand that those exposures in susceptible individuals, people who have developed these intolerances, toxicant-induced loss of tolerance, that's all it takes, is that very tiny exposure to set symptoms off. So this helps people understand their own symptoms and intolerances, protect their offspring, family members, and differences in the susceptibility is going to be due to genetic predisposition, again, differences in detoxification ability, and history of prior exposures. Because if they had a major exposure, think of a Gulf War veteran who was in the Persian Gulf, had exposures there, had some sensitivities and some problems, but then he moved back home to a brand new earth home. You know what an earth home is, right? They built it very tightly, new carpet, new furnishings, everything was new, and he was getting sick and sicker in this house that he had built. It was a retirement home. And his son came in one day and said, "Dad, I think it's this house, not your exposures in the Gulf War, that may have initiated this. Because I didn't have asthma before we moved in this house, and you didn't have all these other problems." So to be aware that, there may have been an initial insult perhaps in the Gulf, but then if you have continuing exposures, if you don't get the Gulf War veteran or the person who has developed these problems out of exposures, they're going to get worse. And so it's possible to interrupt that cycle. And how much time does it take for a physician or a nurse or someone to give a patient this questionnaire? And they can look up information on the web about this. I mean, there's a lot of information on these studies. You don't even have to do that much as a clinician. This is the actually the symptom star, which looks like a little at an angle here. And what you do is you just plot out the symptoms the person has on a 0 to 10 scale. And so this is what this person, the green is what it was like before this woman was exposed in a new office building, a federal office building, not EPA, it was a different building. And after that event, she developed much more severe problems. These are problems with arrhythmias, airway, breathing problems, headaches, cognitive difficulties, affective or mood changes, and neuromuscular symptoms that occurred subsequent to that exposure. And it's a nice way for a clinician, after he or she gives this to a patient, to get a sense, a gestalt on how multi-system is this patient's problems and how many chemical intolerances and food intolerances does he or she report. Because it's validated, it's something you can use as a gauge, a measure, compare that person's tendency toward showing these intolerances compared to other individuals. So we compared the Queasy scores on this little quiz, if you will, between mothers of children with autism, ADHD, and controls. And in the cases of the autism and ADHD, the blue and the dark bars definitely had more of these intolerances, significantly so in most of these cases than did the controls. And that's just a very raw comparison. And then food allergies and food intolerances, food cravings, similar thing that you found many more of these in the mothers of children with ADHD and autism being higher than ADHD compared to controls. So these patterns are there, less striking maybe with ADHD, but certainly ADHD and autism are comorbid. And so this is the questionnaire. This is free to download and use it. And we encourage people to do that. Take it to their doctors. And again, this is the very simple kind of cartoon, if you will, illustrating that we're dealing with a different disease mechanism. And if doctors and patients aren't aware that now their symptoms are being triggered by everyday exposures here, that were not a problem for them and don't bother most people, extraordinarily low levels triggering these symptoms, if that's not recognized, then the person isn't able to recover adequately. They can regain some tolerance over time by avoiding these things, and it may allow them so they can travel or do certain things in the future, but they still have to be very watchful. But again, if doctors don't recognize this, the patients don't recognize this, we're not dealing with straight toxicity. This is not allergy. This is a completely different disease paradigm, and it's a two-step paradigm where once a person has this exquisite sensitivities, you can only help them get better by identifying the triggers and avoiding those triggers. So we've talked about how this TILT, toxicant-induced intolerance, involves an initiating toxic exposure, a fundamental breakdown in innate tolerance. So this is not like, tolerating a drug that you've been administered many times. This is a tolerance that we all take for granted. From the time we're born, we have a certain tolerance for all of our exposures or environment. It's more akin to a diabetic's loss of tolerance for sugars. It's a loss of tolerance that you should have had that tolerance, but you've lost it, and it's a consequence of toxic exposures. And what occurs are adverse and amplified responses to previously tolerated and structurally diverse exposures, including common chemicals, foods, drugs, in adults, alcoholic beverages, in adults and kids, caffeine. One of my most memorable experiences was traveling to Disney World on a flight full of children, with a flight full of children who were just happy and just overjoyed and pleasant. And on the way back, a different group of children, but coming back from Disney World, who were clearly withdrawing from all the sugar and the different things they had on their trip. And they were screaming and irritable and difficult to deal with. So you can see this, these responses in perfectly normal children if you give them enough junk food to eat. Now, what's the evidence for this disease process? It's the fact that there have been similar reports of these new onset intolerances in groups of individuals in different countries and regions. And these are people that don't speak the same languages, don't see the same doctors. Over a dozen different countries that this has been documented. And it's always industrialized countries. And the complaints of new intolerances are for foods, again, alcoholic beverages, caffeine, medications, not just chemicals. And for those of you who have read Kuhn's work on the structure of scientific revolutions, this is key, that why would people in different countries who don't speak the same language, don't have the same media, don't see the same doctors, why would they report after an exposure to a pesticide or a sick building these new food intolerances? How would they know to do that? Doesn't make sense. So to us, this is a compelling anomaly here that can't be explained by existing disease mechanisms. And there's certain resemblance of this to addiction, the food cravings and the withdrawal symptoms. Plausible anatomic locus, we won't talk about it because we have talked about it at this conference, but the limbic system and the hippocampus, and it's an immunological, neurological, probably endocrinological phenomenon. And there's some recent animal models for chemical intolerance. But just like with autism, not enough money being put into this problem, and there are probably a lot of reasons for that, to understand it, to research it, and the complexity of trying to unmask patients so you can even understand this is enormous. So toxicant-induced loss of tolerance, and you'll have access to these slides, a variety of things that seem to induce it, whether it's a drug exposure, various solvents like with glues or paints, indoor air VOCs from remodeling, fragrances, mold VOCs have been implicated, combustion products, smoke from oil well fires, for example, among the Gulf veterans, pesticide exposure, to put those at the top of my list, particularly the organophosphates, and various cleaning agents that people have been exposed to. So there are many different groups of chemicals. These are structurally unrelated chemicals that appear to be able to induce this tilt phenomenon. Just like with the germ theory, many different kinds of bacteria, viruses, and things that can lead to infection and fever. It's a different disease model, but it can account for why you see so many different agents that can lead to this and so many different outcomes. And among the outcomes, multi-system, cognitive, I won't go through all these, respiratory problems, gastrointestinal problems, neurocognitive difficulties, everything you talk about in autism. And these slides were done before I even learned about the world of autism. This was in adults who had had exposures like the Gulf War veterans did. In the environmental unit, we talked about how you can take an individual who may be responding to multiple low-level exposures, and so they overlap in time. They have maybe some effect of food they eat, or driving in heavy traffic, or being exposed to a fragrance, and these effects will overlap in time. And the person's sick maybe all that time, or the symptoms wax and wane for reasons they don't understand. But if you put them in a clean environment, like an EMU or just a very well cleaned up house, those symptoms will play out over time. And what patients report who have done this is the first several days is like going through drug withdrawal, severe withdrawal from all of the things they were exposed to and not even aware that they had sensitivities to. So the first few days are a withdrawal period. Once a person reaches a clean baseline, individual foods, starting with foods, and other exposures at low levels can be introduced, and observe the effects of each of those exposures in the absence, or let's say in a clean baseline, so in the absence of background noise. And this is the goal. And there are parents who have managed to do this on their own. This is just a few slides back when I was younger in Japan, where they did complete an environmental medical unit, and they've used it in that country. They've gone through the kinds of problems that we've had in this country with changes in politicians and then defunding, but it was a beautifully designed unit, one of the, probably the best one that's ever been built, with stainless steel and porcelain on steel walls, glass, nothing that was outgassing, and inside the rooms, it's just, they had wood, but it was polished but not varnished, just polished hardwoods, used a lot of cotton and silk, interestingly. And here is a ventilation unit for a single room, hospital room, which has activated charcoal and HEPA filters in it. Certainly doable. This is very doable. And I'm trying to encourage hospitals to adopt this approach, not just for chemical intolerance and autism, certainly that would be high on my list, but also if you're taking in patients with asthma or with autoimmune diseases, this is the kind of facilities we should be thinking about for our hospitals in the future. You don't want to put people in an environment that's even worse than they came from. This is a beautiful hotel, but we've got these cabinets that are outgassing inside. I don't even put my clothes inside the cabinets because there's glues and like a particle board or something in there that's outgassing, and it will be entrained in clothing. If you get a chance, open the drawers, or open a door and sniff that. So those are the VOCs, and those VOCs migrate into the general room environment. And that's not where you put people who are sick and already challenged. Now this isn't a hospital, so we can do that, but why not just build that way to begin with? So what are the next steps? Adopt what I like to call a personal precautionary principle, which is a precautionary principle, but we have to do it for ourselves to start with because it's going to be a while before the government's going to realize, yeah, we better restrict certain pesticides. We need to inform ourselves and people, as broadly as we can as educators, that they need to be aware of what exposures to minimize in plastics and pesticides and there's a wonderful list that you received a little earlier. Those are the kinds of things we also advise people in South Texas. We teach women and men, low-income Hispanic families, about how to avoid these same exposures, because this should not be just limited to people who are wealthy. These are families that are growing, and they're having kids that are challenged too, and we don't need a generation of kids who, have been compromised for reasons that could have been avoided. So, and then to me, the next step is also to construct environmental medical units, even one hospital doing this and doing it well. I think would set a tone for other hospitals. And I think it would bring patients to their door. If you're dealing with a child who's got any of these conditions, you're going to choose to go to that hospital rather than a conventional hospital. So I think that the economics, the commercial value of having a very clean hospital facility will actually transform the hospital industry in the future. At least that's my hope. The precautionary principle, obviously the most important place for this is during pregnancy, and this will be in the slides. If you email Jane, she will send you my slides. Instead of using pesticides, try using baits and traps and putting things in food containers. We teach this in a hands-on way to people who often have very little literacy, and they get it. We show them these things, using no VOC paint, avoiding strong cleaners. Kind of cute story, we tell them use elbow grease, and water, baking soda, vinegar. First time I taught about using elbow grease down in South Texas, this is in Harlingen and Laredo. Somebody raised his hand and said, "What's elbow grease? Where do you buy that?" And I had to explain, well, actually you don't buy it, and it's hard to explain, but that can be a very beneficial thing to do. One sec. And then finally, avoid scented products. I mean, every patient can tell you, every individual can tell you when something has a scent, just avoid that stuff. The plug-in room deodorizers and so on. Particle board furnishings, like the cabinets we were just talking about in the hotel. New carpeting, try to use something that's non-outgassing, wood or tile, washable rugs rather than something that has to be cleaned with strong cleaners and has a solvent residue. To give you an idea how seriously Japan has taken this whole thing, this is the only manufacturer of housing I know of in the whole world. It's the single largest home manufacturer in Japan. They have over 2 million units of homes they have built, not all to the standard, but they are the biggest manufacturer. And Japan is very concerned about autism because it's very prevalent there, and also chemical intolerance. They've used this queasy, they translate it into Japanese. And so they had me come over and talk to their executives, and actually, God, they did all this kind of promotional stuff and media. And they showed me a little, it's kind of a little suburban area where they've built some homes. They call it Kimi-less, which is kind of cute. Homes near Chiba University, and these are homes that aren't all built to the standards of an environmental medical unit, but still less outgassing and very careful choice of materials. And they feel that that is going to offer a commercial advantage to them in the future, And they have directed their sales efforts toward people who are concerned about chemical intolerance, women who are very concerned about that, and men, and also this rising population of kids with autism. They are taking this seriously like no one in this country is, and to my knowledge, no other country. So my hat's off to them, and here's a commercial enterprise driving this out of concern for the next generations. And this is just a summary slide. All the materials that are here, you're welcome to. If we can be of help in giving you information, some of the training materials that we've developed, be delighted to do that. And be happy to take any questions if there's time.
The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.